Hey guys, this is Sabrina. I wanted to go through the answers for your week 9 assignment. I'm doing this via a new program, so I'm just going to run through my Word document. If you have any questions or it's confusing, please email me and I can help clarify it. For Mr. Hammersmith, the critical thinking scenario, it talks about the protonics and the blood transfusion. So I'm going to just go through some of the common things or something that were a little bit confusing. I'd like to clarify that for you. So initially we do our priorities. We're going to do our ABCs: oxygen, circulation. We have to correct that hemoglobin. So I'm going to think as a nurse, what are my priorities? What do I have on hand? So initially I want to put some oxygen on the man, supplemental oxygen, while I'm waiting for my blood to correct the underlying problem, which is the low hemoglobin, low volume, things like that. So my best outcome is I do not want to delay treatment, especially since 1 unit of blood can take anywhere between 2 to 4 hours depending on how well they tolerate it. So in that case, I would want another IV site. I'm going to have 2 separate IV sites. My first site will be for my red blood cells, my packed red blood cells, with the normal saline. That's part of a protocol and policy. Those will hang together using the filter tubing. Now, depending on how quick I have that blood available from blood bank, I could potentially use the IV that I currently have, the 20 gauge in the right forearm. Or the better one would be to start a new IV with an 18 gauge, which is wider to administer the blood. Keep in mind, it's a team effort. It's possible that if you have a patient who needs multiple orders processed, you can delegate or ask a fellow nurse, like, hey, can you go ahead and start an IV for me? I'm giving blood. I need at least an 18. Or, hey, can you give someone this pain medication? So you can work together with your team and delegate. Don't forget that part of it too. So with our second IV, that's where you would have your protonic strip. We know it's compatible with normal saline and LR, and you looked up the compatibility on some questions later down. And there's an order for normal saline at 100 milliliters. Okay? So keep in mind the fluid volume overload. This gentleman will have blood running, okay? And we're going to have protonics running and normal saline at 100. That can be a lot of volume at one time, so you're really going to have to monitor if he is tolerating it. If not, you're going to have to call a physician and there might have to be some modifications, okay? So if we were in lab, this is what we would demonstrate to you. This is an Alaris pump, what you're familiar with. These medications could technically be ran together, but on their own channel. When I mean medications, I mean the protonics and normal saline would run on one pump, one brain. You would have your protonic strip set up on one channel at the rate that was calculated, and your normal saline at 100 on this pump, which would be channel B. So you have your brain, channel A, channel B. So you can infuse your protonics and your normal saline at the same time through the same IV. In this case, we'll call it IV number 2. Okay? So if you scroll down in this Word document, channels are part of the pump where the IV lines run. They're programmed for the drug running through them. In essence, over here you're going to have IV site number 2. You'll have protonics in a bag through one channel, normal saline at 100 through another channel. You're going to connect it at a port close to the patient, or there are some adapters like that have 3 separate ports, so you can connect multiple tubes to the same IV. Okay? So when we talk about Y-siding something, it's where at one point they're going to mix together. So both are infusing at the same time. Protonics, saline, one IV. Where it's different, a piggyback, remember you're going to have one line, but the bag is connected at the port above the pump. If you hang it as a piggyback, you can only run one bag at a time. That is why they have to be on their own channels. They have to have their own rates. Okay? So again, be cautious of that fluid volume overload. Moving down, there was some students who were talking about the normal drug dosing and what it's used for, the indication. Protonix is a PPI and it's used for many different indications. The action of the drug is the same. What we're trying to accomplish depends on the route, how much, and the indication for it. In this case, for Mr. Hammersmith, he had a GI bleed that was fixed, was cauterized per the procedure. So now we want to prevent him having any more of a rebleed. Okay, so Protonix is a very effective drug to prevent rebleeds and is used as treatment for any kind of GI bleed. Okay, so when you go to your evidence-based practice or reputable resource, whether it's LexiComp, the drug website itself. In this case, I found that 80 milligrams IV bolus infusion over 30 minutes, followed by 8 milligrams an hour concentration, is an appropriate dosing. Okay? Now, switching gears. Remember we asked that other nurse, like, hey, can you start an 18 gauge IV for me? She was successful. She got an 18 gauge, simple, easy, good patient, good veins. Now you're going to set up your blood transfusion, and that was part of your checkoff, and we did discuss that in college lab, how you would set up blood products. That will be on its own, ideally its own pump and channel. You could put another channel, a channel C, on the one up here, okay? To keep it nice and simple, I might just grab a whole new pump and channel, but you could run up to 4 channels on one brain, okay? So that's our blood setup. There was some students who did really well to talk about preventing ulcers and prevention and teaching. So we talked about avoiding spicy foods, citrus, fatty foods, caffeine, coffee, your chocolates, anything that would be irritating to that mucosal lining. Alcohol consumption, we get a better history, things like that. Take NSAIDs with food to decrease the risk of irritation, unless that is not a good option. So that's something that would be a doctor discussion, a team thing. Hey, should he really be taking any more NSAIDs because of this risk of bleeding? Okay, and then of course there's always our stress and exercise and relaxation, things like that. Okay, so there's a lot of family and patient teaching opportunities. Switching gears to your SBAR. Everyone did a great job. Good identifying who you were, your assessment, your background, perfect thing like that. What I want you to be mindful of is that there was one student, as she was reading this, said, hey, there could be a possible transfusion reaction. Absolutely is an option. The symptom you're told is abdominal pain. That's a pretty vague system. So if we're going to make a decision tree, if we're trying to break down which way I'm going to go with my critical thinking, abdominal pain is his symptom. Knowing what we know about blood transfusion reactions, not tolerating Protonix. He just had a procedure that he had his stomach cauterized, things like that. What other questions will we want to know? What other data, vital signs, what other things do we want to know so that way we can narrow down what could possibly be going on, okay? So just be mindful of that to get those PQRST questions of your pain. Okay, the quality, does it radiate, severity, the timing, things like that. Okay, in this case, our critical thinking led us to he's having pain that's not related to a blood transfusion. Okay, so let me go backwards. If it was a possible blood transfusion reaction, that's just one symptom. What would be our action if there's any reason to suspect a blood transfusion reaction? We stop the blood, start a new line of saline, call the doctor, and go from there, and then monitor for symptoms. So there was 1 or 2 students who kind of took that route, so good thinking. All right, switching gears to our actual setup of the IV drip itself. As I said before, Protonix is going to be in its own bag, and it's going to be a continuous infusion. So we're going to have it set up on our one channel like I pictured over here. Now you have an order for morphine. Okay, we're going to be giving an IV push medication through an infusing IV. In this case, we have Protonix running, And over here, remember, we have normal saline. So in essence, the morphine is going to directly mix with the Protonix, because this is where we're giving our IV push, right? So doing our check-off thing, we got to check compatibility. Are Protonix and IV morphine compatible? The answer, after looking up your credible resources, is yes. Okay? So then we'd go on to safe administration of IV push morphine. If the compatibility is unknown or it's deemed incompatible, what is the safest way to administer this medication, this IV medication? Okay? So we'll use morphine, IV push, or any of IV push meds. We're going to do the port closest to the patient. Okay? If he has saline running in its own line, it also has a port. Okay, so it gets a little tricky. What I'm trying to accomplish is appropriate compatibility and timing of the drug administration. How long does it take to have IV push morphine? So what is the recommended time? That would be your drug calculation. Okay? Again, if you had something not compatible, you could pause your Protonix, because remember, it's on its own channel, right? So I could pause this one, run my saline, give my medication. Or you can pause Protonix, keep your saline running. You can get another 2 normal saline flushes. So I would flush my normal saline to clear the med that's not compatible, give my IV push morphine, flush with saline, resume my Protonix. Or, I'm sorry, any medication that wasn't compatible. I'd resume this one. The other picture I have here for you is breaking down the IV tubing. So when we're looking at it from this picture, this is where your bag would be, drip chamber. This is a part where it could Y-site. If you were giving a piggyback, this is where the line would attach. Your pump would be right here, roller clamp, port closest to the patient, where this actually connects to the patient. Okay? Switching gears. It's easier to see this when you get on the nursing unit, but Protonix itself comes in different forms. It can be given as in a vial. Okay? In this case, it's for injection, IV push. So it can come IV or PO. So when you're doing your patient education, a lot of you were saying about the oral dosing of Protonix, but remember, at this point, we're giving it IV. We have to be prepared and explain the reactions of an IV infusing medication. Okay? If the patient were to be discharged home on the oral dosing, of course, that'd be a separate kind of teaching on how to take the oral medication. Okay? So, depending on where you work or how it's stored, you're going to get Protonix vial. This happens to be a 40 milligram. You would reconstitute it with some saline, and then you would administer your IV push or the frequency of how often they're supposed to have Protonix. In Mr. Hammersmith's case, it's a continuous running, so we're actually going to be getting from pharmacy a bag that looks like this that has Protonix mixed in it. Okay? So continuous IV fusion, you're going to get a bigger bag. If it's something where you're giving intermittent doses, like an IV push, you're going to be getting it as a single vial. Okay, so you have to be conscious of your tubing, your setup, and compatibility. If you have any questions, please let me know. There are some YouTube videos that can kind of help give you a better visual. I didn't want to record myself because there are some good videos out there. If this is unclear at all, make sure you let me know. Okay, thanks guys. Bye-bye.